Hello and welcome to Face to Face. Today we are face to face with too many pills. Drug use is on the rise among Canadian seniors. Are doctors too quick to prescribe medications to older patients? And if they are too quick in prescribing, why? Today's guest is Alan Castles, a researcher at the University of Victoria. He wrote about this issue in the March edition of Reader's Digest, and he joins me now to talk about the wider issue of prescribing drugs or over-prescribing drugs to seniors. So, Alan, what exactly is going on here?
Well, let's look at the statistics. So in 2005, the average person in Canada, say between the ages of 60 and 69, took something like 35 prescriptions a year, okay? When we looked at people 75 and over, those people were taking 74 prescriptions a year. So really, the sheer volume of prescribing tends to rise as people get older. We know that older people are getting more drugs than younger people, and we know that compared to, say, 20 years ago, they're getting a lot more medication than they did back then.
I just want you to go over those numbers again because they sound so just crazy. People, I don't remember the age, but people over a certain age are taking 35 prescriptions a year?
Yes. So, that sounds like a lot. If you're taking, say, 3 prescriptions per month, that would add up to 36 prescriptions a year, right? So we're talking about so you go and visit the pharmacy, once a month to renew your prescription. Okay. So you might be getting 35 prescriptions a year. So somebody over 75 is taking something like, on average, 74 prescriptions per year. And that's on average. So you would get other people who the numbers of prescriptions could be in the hundreds. And these would be people who might be taking 10 or 12 or 15 medications at once.
10 or 12 or 15 sounds absolutely amazing because these are powerful things.
Well, for sure. And when you look at the kinds of ways that they deliver drugs to elderly people, like people in long-term care facilities, they use these things called bubble packs, and each little bubble represents a day. And in each bubble, you might have 10 or 12 different drugs that the senior is supposed to be swallowing that day. It's a way to organize their drugs, but also just looking at these, it's just the sheer volume of it is really quite astounding.
So somebody would come up to you with 10 or 12 pills in the morning and again in the evening?
It might be a daily thing. You might take 2 or 3 in the morning and maybe some at lunch or maybe some in the evening. That's right, yeah.
Now, so we're talking 10 or 12 pills a day, which sounds substantial. But is that way off the graph or off the chart in terms of the average or?
Yeah, well, it's certainly off the chart in what it should be for the elderly. And let me explain that. In that older people, we know, have more medical problems, and that's one of the reasons why they're going to get more drugs. But they also are more likely to have interactions with the drugs that they're taking. Each time you add another drug to their existing pile of drugs that they're taking, you're potentially adding more problems. So this idea that you would be giving multiple prescriptions for each person, you're increasing the dangers that person is going to be subject to.
Your story in the Reader's Digest starts off with the story of a young woman, I think. Well, maybe you want to run through that story?
Yeah, well, actually, it's a young woman who told me the story of her mother-in-law. And the mother-in-law was 87 years old. She was living in a facility on her own. She woke up one morning a little dizzy. She had a bit of a fall. Next thing you know, she's in the hospital. So once she gets into the hospital, she's given drugs for her heart. She's given drugs for her blood pressure. She's given drugs for anxiety. She's also lonely now that she's in a hospital and away from her friends. She's given antidepressants. And next thing you know, she's given drugs for Parkinson's. Now, you might say, well, all of that sounds particularly appropriate. But part of the problem is that some of the drugs that she's given are causing side effects which the doctors are then treating with more pills. This is what we call the cascade. So you get 4 or 5 or 6 medications, they interact, you have symptoms, maybe dizziness or weakness, and the doctors sometimes add more drugs on top of it. And so you get this situation where it's a snowballing effect. And in this particular woman, her name was Fervid Trimble, and she ended up in a hospital for several weeks. She was quite essentially overdrugged, and this was recognized by her daughter-in-law. And her daughter-in-law went to the facility and said, "We believe that our mother is being given too many medications. Can we talk about this?" And initially they were very dismissive and saying, "We're the professionals here. Who are you to tell us how to practice medicine?" But her daughter-in-law did a lot of research and found that the specific symptoms that she was seeing in her mother were actually being caused by the drugs that she was given. And then she went back with her research and said, "We believe that these new difficulties that Mom is having is due to the drugs that she's taking. Can we talk about this?" And she actually had the ear of a fairly sympathetic nurse who spoke to the doctor, and slowly they started to wind back her prescription drug regime so that it was down to a sort of more manageable level. And surprisingly, once they started taking away the drugs, she got better. She started feeling happier. The so-called Alzheimer's symptoms that she had went away miraculously.
And of course, she was getting drugs for the Alzheimer's.
For sure. And the drugs that she was given that were causing a Parkinson's-like symptoms, a stiffness, and agitation, those drugs were taken away as well. So essentially, they made her better by reducing the number of drugs that she's on. And I think it's a very telling lesson that people who have their mother or their grandmother or grandfather put into an institution and they change, they physically change quickly, that it's probably due to a drug.
Now, you said this lady was in a facility when all of this started to happen. What kind of facility is?
Yeah, it would have been an assisted care facility, so sort of like a senior's home. They would have probably had doctors on call, nurses on staff, and that kind of thing.
So when all of this happened, did this facility suddenly say, well, maybe we should start doing this for all of the seniors in our care?
You would think that would be the case, but I don't think that's the case. I think in terms of winding back the overdrugging of seniors, you have to have insistent advocates working on your behalf, and not all facilities, I think, would be in this category. I mean, there are some doctors out there that really recognize. In fact, I interviewed one of the physicians in this story, is a doctor named John Sloan, Dr. John Sloan from Vancouver. He wrote a book, came out just last year, called A Bitter Pill, and it's about how we over-medicate and over-treat the elderly. His point being is that whenever he sees an older person with new symptoms, the first thing he suspects is a drug. And I think he's become a bit of a medical sleuth in determining that a lot of the problems caused in the elderly are caused by the too many drugs that they're getting.
That's probably worth repeating, which is that when he sees new symptoms in an elderly patient, he
always looks for the drug culprit, and typically it will be a new drug that's been added or a dose that's been changed and that kind of thing. And really, you might say, well, why are seniors so subject to so many medications? As I said before, one of the reasons is that they just simply have more medical issues. So they might have arthritis and a touch of anxiety and some weakness in their bones and so on. So those things sometimes would be appropriately medicated. But a lot of times what they need is compassion. They need someone to listen to them. They need someone to deal with their worries and their anxieties in a way that they don't have to use drugs.
They could probably also use medications that help them.
Yes.
And don't cause side effects.
By all means.
And I think the drugs we do give, because basically what the pharmaceutical industry puts out is simply drugs that treat the symptoms. They Are there any cases where they actually try to solve the problem?
Well, there's certainly cures are few and far between, if that's what you mean. But let me tell you what I think is probably one of the biggest scandals, certainly in medicating the elderly, is the use of drugs that were designed for schizophrenia. And so these would be what we would call antipsychotic drugs. These would be drugs like Zyprexa or Seroquel. Extremely powerful, very toxic, and these drugs are used routinely in long-term care. In fact, there's been research done recently that something like 30% of seniors who are put in a long-term care facility within a year are going to be put on one of these drugs.
Now that's worth repeating too. 30% of...
Yeah, 30% of seniors within a year of being put in a long-term care facility is put on an antipsychotic drug. Now, most of the time, the family doesn't know that these are antipsychotics. The person who's swallowing the pill doesn't know. Physicians are using these drugs as a way to calm down agitated people, sometimes to help them sleep. But they're like using an elephant gun to deal with a kitten. These are very toxic and widely overused. Furthermore, there are also warnings against using these drugs in people that have dementia. In fact, Health Canada has come out with a warning saying the antipsychotics should not be used in the elderly with dementia. Well, a lot of people in long-term care have dementia, and a lot of those people with dementia are going to be put on these drugs. So clearly, something's falling between the cracks.
Well, it doesn't. That sounds more than falling between the cracks.
Yeah.
This sounds like the system has dementia.
The system certainly has problems when it comes to dealing with, and you could probably understand why some of the facilities are using too many drugs. They probably don't have enough nurses or enough care aides to help people. They probably don't have enough non-drug ways of dealing with anxiety or loneliness and that kind of thing. And they probably forget the fact that when you add another drug onto an existing drug regime, you're actually adding the potential for more problems.
Well, I have a feeling they don't forget that, because even I know that. Everybody knows that.
I mean,
they must know that.
The data, really backs this up. So in Canada, we have a system called the Adverse Drug Reaction Reporting System. ADR is an adverse drug reaction. So if there's a serious reaction that causes hospitalizations, severe illness or death related to a drug, those reports are often sent to Health Canada. They collect the reports on these. The seniors in this country, so people over 65, make up about 13% of the population. When we look at the data on adverse drug reactions, about 45% of the adverse drug reactions are in the elderly. So we know that serious harm to people is really over reflected in elderly people.
I would hate to suggest that somebody is making money from all of this, but is that in fact happening?
Well, it's always worth following the money, and of course, in the case of the use of antipsychotics, we know that they have been widely marketed and widely pushed to physicians to be used in long-term care facilities, as well as a lot of other things, antidepressants, anti-anxiety drugs, and drugs for things that you really wouldn't think would be necessary in the elderly. I'll give you an example. Drugs for lowering cholesterol or drugs for blood pressure. These drugs are designed for younger people. They're drugs designed for preventative purposes. You give someone a cholesterol lowering drug or a blood pressure lowering drug because you want to reduce the risk of having an event like a heart attack or a stroke. Well, when someone's 85 or 90, what are you really trying to prevent? Using preventative drugs in someone who might be 45 or 50 years old, who has 50 years ahead of them, that may be a wise thing to do. Using that same kind of drug in the elderly really doesn't make any sense.
Because the prevention aspect is going to come in 5 or 10 or 15 years when the person's going to be 100.
Well, the other thing too is that as you're trying to achieve prevention, you're causing side effects. These drugs are not benign, and again, they're added to the chemical soup, which comes the.
Well, I want to get back to the story of the woman whose mother-in-law was in a care facility, I guess in Vancouver, is that? And she followed up. She went to the doctors. She said, "We think that the problems she's now having, these new problems, are being caused by the drugs you're giving her."
Right.
And after a short while, the drug regime was changed, and the problems, in fact, went away.
Yes.
What is interesting to me is that nothing has changed, because probably aside from her mother-in-law, everybody else is still getting exactly the same drug. Why?
By all
Why?
means. So you mean in terms of a big societal change or the facility
What's
changing?
the pressure to make this insanity happen? Although I guess you explained a few of them, but what are the cost of these drugs?
Well, I mean, clearly when you're taking 8 or 10 or 12 drugs a day, the costs are huge. I mean, the drug regime of an elderly person could be $400 or $500 or $600 a month. In some cases, that just gets tacked on to the cost of putting your mother or your grandmother in a long-term care facility. That gets added to the bill, and so yeah, the costs are huge. So you have to ask yourself, if we're spending all that money and making people sicker, maybe we should spend some of that money to reduce the problem. And I think in this case, certainly with drugs, it's a complicated problem. Some of those drugs might be very essential and very life-protecting, but many times you're causing more problems by adding more drugs into the mix.
Now, you mentioned earlier that in these facilities, there's not enough money to do the kinds of things that would prevent boredom and stress and sadness that leads to the taking more drugs. But if you had $300 or $400 per person per month, by reducing the cost of their drugs, right, you could then hire the people necessary to take care of them.
By all means, and I think in the sort of progressive way of looking after elderly people, you need to involve people. You don't need to involve more and more drugs. You actually have to have people who can coordinate, activities and can actually be there to do what healthcare is really about. It's about caring for people.
So let's get down to brass tacks here. I mean, when I hear this story, and it's not a story I think about too much, but when I hear a story like this, I think behind this is some powerful force that's creating a system that is making drug companies a lot of money.
Yes.
And at the same time making our parents and grandparents sick.
Right. And so that's undeniable that the pharmaceutical industry is really behind very much the education of our doctors in the use of drugs. And we know from our research is that physicians actually don't learn very much about the side effects or adverse effects related to drugs. I mean, that seems shocking, but when they're getting their information from the drug companies or from specialists who are hired by the drug companies, they're only getting half the picture. I mean, that's why it's really important to actually have family involvement, if possible, or if you're the person taking the drugs yourself, to be asking the questions, are these really necessary? Really, what are the issues that you're trying to prevent with additional drugs, and are there safer kind of alternatives?
And of course, that should be the number one job of the facility. They're the ones who should be making sure that everything is on the up and up.
Right. But it's not just seniors in facilities who are subject to this problem. I mean, seniors who live on their own in their own homes. You go and look into their medicine cabinets, and you see astonishing piles of medications that many times are simply overkill to the nth degree. Yeah.
And one problem is that our doctors have no other weapons except these drugs that come from the drug companies. They're not trained in anything else.
Well, that's true to some extent. And what also is true is that a lot of times the drugs that are in the market are never tested in elderly people. So they might be tested in younger people who are 45 or 50 years old, but then they get used in somebody who's 80 or 90, which John Sloan said in this article that I wrote. He said it's an evidence-free zone. we don't know what the evidence is around treating elderly people for cholesterol or for osteoporosis and those kinds of things. Those drugs are tested in younger people. It's a different game when you're giving them to older people.
Yeah, and personally, I don't trust the testing anyways because it's all done by the companies. So, in Dr. Sloan's book, A Bitter Pill, you said there were some interesting lessons about the physician's side of treating the elderly. What does that mean, the physician side?
I mean, I think that John Sloan, who spent several decades treating people in their homes, and traveling around Vancouver with his car, actually treating the elderly in their homes. I mean, the one thing that he would probably say is that, again, most of the new problems that he sees in older people are often caused by new drugs that they're getting. And the problem is really exacerbated when you have an issue and the person ends up in a hospital. And that's when the full onslaught of the medical machine works on you, where they will prescribe drugs for virtually everything. And his point is that if we could treat people appropriately in their own homes, i.e. have doctors visit the elderly, see how they're living, see if they're getting enough food, kind of see what the sort of care issues they have, we would be able to save hundreds of millions of dollars from unnecessary hospital visits, and we would probably be saving lives by doing so, by treating the elderly actually where they want to be, which for the most part, not always, but for the most part, if they can care for themselves and want to be comfortable in their own home.
Plus, it would be a nice job or jobs for people.
By all means, yes.
And is there anything people can do? I mean, because this upsets me just hearing about it. It bothers me on many levels.
Yeah. I guess the simple answer is, and this sounds like my personal mantra, is that a level of healthy skepticism when it comes to prescription drugs is absolutely essential, whether you're talking about drugs for your child, for yourself, or your elderly parent or grandparent. I mean, being skeptical about what's being prescribed, asking lots of questions. And I think that physicians, some of them, if you can be polite but forceful and say, I would prefer a non-drug option, or we would prefer alternatives. We don't want grandmother to be taking another pill onto the 10 that she's already taking. I think that if you can ask these questions, then the doctors can start working with you. You don't want, I think, really come out and say, we think all drugs should be thrown out. Throwing out the baby with the bathwater is probably not the solution either, but being forceful, asking questions, and then finding out really by doing some of your own research, and there are some very good sources on the internet for bestpillsworstpills.org, a very good source.
Bestpillsworstpills.org.
Yeah, I think the website address is worstpills.org. It's an excellent site, American site. There's the Cochrane collaboration. That's Cochrane.org.
Cochrane.
That's correct. And we have a good source here in British Columbia, the Therapeutics Initiative. If you just Googled that, you would find this group at UBC that tries to develop independent information for physicians. So, I mean, there are some good sources out there. Probably 80% of what you see on the internet, though, around drugs is marketing. So you have to be fairly careful, and you have to know what and who is behind saying anything about any drugs. The pharmaceutical industry is getting much better at doing social media, and very savvy about getting buzz around their treatments on the internet. You have to be aware of that kind of stuff. And I think that asking questions and doing your own research is probably the best way to protect yourself.
Okay, so there's a bit of good advice for everybody. Well, the next question I was going to ask was, what questions should people have of their medications? But, well, you gave the sources, but what are the questions?
Yeah, I guess the questions is, you got to find out what is the name of the drug. Because if you find out the name, and that would be the brand name or the generic name, then you can do a bit of research yourself. You can find out what is the official product monograph, or the official label, as it would be called in the U.S. And that list, that's the government-approved label. So the company describes the action of the drug, what it's prescribed for, how it's supposed to be used. And really knowing For example, in the case of, say, your elderly mother being prescribed something like Seroquel, reading up on that, the first thing you would find out is that this is an antipsychotic drug. This drug is to be prescribed for people with bipolar disorder or schizophrenia, and this drug should not be used in the elderly with dementia. You could find that very quickly with the approved product monograph. So knowing the name of the drug is what I'm saying. And then finding out what are the potential side effects, what are the potential adverse effects, meaning the more serious form of side effects. And then you can start asking questions around how long should you be taking it? How long will it take to know if it's working? What will working look like? People don't ask these questions. People say, they take a drug and they'll say, well, I'm just supposed to take it forever. Well, why would you take something forever if it's not working or it's making things worse? So getting a real clear idea of what working looks like, I think, is really vital. And then you could start asking about alternatives. I mean, if this is the drug on offer, what else is there? And for every condition that there is out there, there is drug and non-drug approaches to treat it. So I think asking about alternatives is really an important question.
Okay. Unfortunately, we're running out of time, but I understand you've got a book coming out on the testing industry. And maybe you can just say, what is the testing industry? And tell us something about the book.
And certainly related to the overprescribing in seniors. Seniors, like anyone, get so many tests. They'll get tests for osteoporosis, for blood pressure, for cholesterol, for all kinds of things. And a lot of time, what's driving these tests, and a lot of times these are screening tests, what's driving them is a visit which ends in a drug. And what I'm doing in my next book, and I've tentatively said that there's a character in there that I would call TETO, T-E-T-O, which stands for test early, test often. Because really that's the mantra which is driving a lot of inappropriate screening and inappropriate drug use. Test early, test often. And I think that what I'm hoping to do with this book is turn that over on its head, where a lot of times testing early actually doesn't make you more healthy, doesn't actually give you more options, may make you more worried, may subject you to more and more invasive medical tests, and may actually cause you to take drugs when you don't really need them.
But does make a lot of money for somebody.
By all means.
Yeah. We've been talking to Alan Castles. Alan, thank you very much for this and some, I think, very good advice on an issue that maybe a lot of us don't think about too much, but some people are directly affected by this on a daily basis, and I'm sure a very large number of people. So please take Alan's advice to heart and start checking into these things. Thank you, Alan.
Thanks a lot, Jack.
And thanks for watching Face to Face.